Hello, I'm Dr. Monica Kraft, the System Chair of Medicine from the Icahn School of Medicine at Mount Sinai, and we're in Aspen, Colorado at the Aspen Ideas Health Festival, and I'm talking to Dr. Dolores Malaspina about mental health, particularly depression. Dr. Malaspina, would you like to introduce yourself?
Yes, with pleasure. I'm Dr. Dolores Malaspina, as stated, and I'm a professor of psychiatry, neuroscience, and genetics at the Icahn School of Medicine at Mount Sinai.
Great. Well, great to be with you today. So I wanted to ask you a couple of questions. Why is it important to address depression as a way of improving women's health?
So, people don't realize that the number one cause of disability in the U.S. is major depression. And depression is twice as common in women as it is in men. And what we know is that untreated, of course, depression is a risk for suicide, but also cardiovascular disease, early mortality, and many other inflammatory conditions. Many people will just tolerate depressive symptoms or not realize they have them, but certainly 1 in 5 women now will suffer depressive symptoms in any given year. So the rates are ballooning and skyrocketing, and we need to be able to screen for depression and treat depression.
Well, along those lines, I understand depression's underdiagnosed in women. So why do you think that is?
Yeah, so it is interesting. Many times a woman, may feel that her symptoms are an issue of character, or she should just buck up, or a woman might go into overdrive, might have so many different responsibilities that they keep chugging along. But what you see is the evenings and the weekends, there's no energy left, right? There is this great depletion. Also, a woman will go to her doctor often with other symptoms, maybe palpitations or difficulty catching a breath, GI symptoms or pain. And the doctor will do the workup and say, good news, you're all right. She wasn't all right. Right. They've missed the depression, which is treatable.
So what you're saying is depression can present actually without sadness.
Absolutely.
And that's actually something that I don't think is really widely understood.
Yes, over half of women and half of men or more with major depression, treatable major depression, have no sadness. So the docs will often screen by, well, are you sad? No, right? But there's this loss of pleasure, and it's a little more sophisticated to understand that someone isn't quite seeing their friends as much as they used to, or not reading their favorite books, or doing their hobbies, or has to drag themselves to a child's recital. It's that loss of pleasure that's more of an indication of the depression.
And do you think especially primary care providers, can they use any kind of scales or surveys to try to get their arms around this really important issue?
Yeah, we have several really good screening tools. The PHQ-9 is 9 simple items, but it also can be just 3 or 4 items. Screening for depression must be a part of every physical exam. Now, the newest guidelines is without any symptoms at all. Everyone should still be screened for depression and anxiety. Many people just conceal,
right?
Or there's such a stigma. Yep. They don't want to mention it. Or they'll be told, oh, you have no reason to be depressed. Depression because of a catastrophe or a death is just as treatable as depression without any good reason. So after a first trauma, we think you've kindled a depressive illness. It can come and go.
Yes. Very interesting. So speaking of treatment, what are some of the promising new treatments?
Well, let me talk about the promising existing treatments first, because they are underused. Okay. So we have a large group of medicines. We call them the SSRIs. For all medicines treating depression, the goal is that they've improved the plasticity of the brain, the making of new brain cells, the strength of the connections between regions of the brain. So we're aiming for neuroplasticity. And some medicines that target just serotonin can increase brain growth factors. Others are through norepinephrine receptors. But in each of these instances, we're leading to improved brain growth factors. Now, getting to the right dose of these medicines is important. And we look to have had at least 2 good trials, one on an SSRI and one on another medication. But for the small group of people who don't respond, We have many new treatments. We have ketamine, which can be infused and pretty soon can be administered in other ways. We also knew for many years the best treatment of depression was ECT, electroconvulsive treatment. That carries a lot of stigma and fear. Now we have neurostimulation, treatments that don't involve anesthesia, and those are being perfected. So there's lots and lots of hope. Just about everyone with depression can aim to get all the way better. And let me also add to that, depression really is a chronic disorder. If you've had one or two episodes, we know the chances are that it's going to recur. People need to find medications that work, or psychotherapy can very often work as well. You know, I kind of skipped over that, but I should say that by reconceptualizing a stressor, just through cognitive behavioral therapy, many persons can have remission from depression. So we have a top-down approach with different types of cognitive behavioral therapies. So think of the medications as kind of bottom-up, increasing those brain growth factors, and both together work wonderfully well.
Excellent, excellent. Well, how do I know that a treatment for depression is right for me? There's so many out there. So how do you decide what's right for me?
Yeah, so that's such a great question. You know, we have algorithms, of course. I mean, myself, I'm on the steering committee for the DSM-5. So we write the criteria for the different symptoms of depression. But pretty much we make sure, is this depression part of bipolarity? So we'll want to know, was there ever a mania? That will change the way we treat the depression. And then as a part of this depression, does someone have a contorted view of reality? Perhaps they're hearing voices, or they have delusions of bodily injury or control. If there's a psychosis, we'll treat it differently as well. That's a minority of depressions. For the most part, a standard medication will be started, and the dose needs to be increased to a therapeutic dose. Most people will just feel better on something. Doesn't mean it's the right treatment. You really are aiming for the remission of symptoms. I mean, it takes really a visit to really know someone to see if the symptoms are resolved. A doctor can't just check off a box, oh, they're better, and continue the same meds. It takes that interaction.
What about precision medicine-based approaches? Are you using any of that to really decide on what medications to give your patients?
Yeah, so I would say for depression, remember we're talking about conditions now that affect such a large majority of persons. So we do have certain genes that we know about, but there are hundreds of genes associated with depression. It's highly heterogeneous. So we can look for trauma-informed care. So we can see if there has been a trauma and address the trauma as a part of the treatment. But at this point, we're still collecting the data.
It's a lot of work being done.
A lot of work being done. But we know the sooner you treat depression, the better. You know, and that's the promise as well. Hopefully there's less and less stigma.
I think that's key. And so is there anything else you want to let us know about the innovation happening in this area? Yeah,
so I think, you know, there's excitement that we can stimulate some very specific area of the brain in an awake, conscious person, and that can change the plasticity in the circuit, and may lead to complete treatment. At this point, we still will keep people on medications with these brain stimulation treatments, but that possibly will not always be the case. Right. And you know, the vagal nerve is part of our autonomic nervous system, and we think of the fight or flight connected with sympathetic activation. But in depression, we have too little vagal, parasympathetic. So there are vagal nerve stimulation treatments underway in development as well. So I think the future is filled with promise.
Wonderful. And that's really going to help advance women's health without a doubt.
Absolutely.
All people's health.
Yes.
But and so I thank you so much for your really insightful comments.
Thank you. Thank you.
Great. Thank you for joining us.